Hello, and thank you for joining us for this session on rare ovarian cancers. We'd like to thank our sponsor, Veristem, for making this session possible. In this session, Dr. Jubilee Brown will discuss what's new in the landscape of treating rare ovarian cancers. Dr. Brown is professor and director of gynecologic oncology at the Levine Cancer Institute at Atrium Health in Charlotte, North Carolina. Thank you, Dr. Brown, and I will turn it over to you.
Hello, my name is Dr. Jubilee Brown, and I'd like to thank Elizabeth White and the leadership of the OCRA for the opportunity to speak with you today. It's such an honor to be present with you, even if it's virtually. So I'm happy to join you today. So I'm the professor and division director of GYN oncology at Levine Cancer Institute in Charlotte, North Carolina. And I've been asked to speak today about something that's very near and dear to my heart, which is progress in rare ovarian tumors. So without any further ado, let's get started. So these are my disclosures. And today what we'll do is talk about rare ovarian tumors. Basically, these are the zebras in gynecologic oncology, not so much the, if you will, everyday ovarian tumors and ovarian cancers that we're used to seeing, but these are really the unusual types of cancers that we see. They're managed very differently, both surgically and from a chemotherapy and immunotherapy perspective. And so I'm excited to share that information with you. I've always been told that good research tells a story, and sometimes that takes a while. So it's taken me my sort of whole lifetime. This is me way back when, and I am just a little bit older than that now. So this is sort of my life's work, and I'm excited to share that with you. So when we talk about ovarian cancer, let's talk about what the three major groups of ovarian cancer are. And they're epithelial, which are the most common, and then germ cell, which tend to happen to adolescent young patients, young women, and sex cord stromal tumors, things like granulosa cell tumors. So we'll look at these differently because there are very different characteristics and treatment recommendations that we use for each of these. So we'll start off with epithelial tumors because they account for about 90% of all of the ovarian cancers that we see. And these include high-grade serous, low-grade serous, mucinous, endometrioid, clear cell, Brenner, mixed, and undifferentiated tumors. And the rare subtypes that we'll talk about are low-grade serous, mucinous, and clear cell. So let's start off with low-grade serous. These tumors represent about 5% of all epithelial cancers, so not a lot. When we look at them under the microscope, this is really what we see. They can either arise by themselves or after borderline or low malignant potential tumors. These tumors can arise from those. They tend to be diagnosed at a younger age. They have better survival than the typical high-grade serous carcinomas that we see, like that garden variety type of ovarian cancer. But unfortunately, still about 70% of advanced stage patients do relapse. And the usual, paclitaxel carboplatin chemotherapy that we're used to giving to these patients, it's just not very effective. And that is because different pathways are active in low-grade serous carcinomas compared to high-grade serous carcinomas. And so we've made really a lot of progress in the last several years due to MEK inhibitors and hormonal therapy. These are drugs that are really useful in low-grade serous carcinomas. Just recently at this year's ASCO, we sort of learned more about why that is. There's the RAS pathway that are most common, and that's why MEK inhibitors tend to work in these patients. So just to do a little deeper dive into that, MEK inhibitors are not all that common in gynecologic cancers. This all started several years ago with investigating selumetinib in our large cooperative group trial. It's GOG 239. We do a lot of rare tumor work within GOG and the NRG. So selumetinib was found to have 15% responses, but 65% had stable disease. And so this was deemed an active agent and led to some other trials, specifically the MILO trial, where another MEK inhibitor called binimetinib was compared to physician's choice chemotherapy in patients who had recurrent or persistent low-grade serous carcinomas. And what we found actually was that there wasn't really any difference in progression-free survival in the intent to treat group. But if you actually look, very interestingly, this is a waterfall plot that shows substantial improvements. What we see here is that these bars here represent decreases in the tumor volume. And you can see a lot of blue over here, right? So binimetinib actually worked in a lot of patients with really deep responses. Surprisingly, you'll see some of these brownish bars too. Physician choice, the chemotherapy, conventional chemotherapy worked a little better than we had expected in this group. And so the percent of patients with complete or partial response was actually the same. But interestingly, this may have been confounded because remember how we talked about the RAS pathway being activated? Well, the bottom line is if you pull out the patients who overexpressed RAS and would be good candidates for MEK inhibitors, well, in that group, it actually did work. Look at this, the p-value of way less than 0.05. And we did in this group see a difference favoring binimetinib in this group. Now, interestingly, trametinib was studied in GOG 281, and in this trial, there was a significant benefit to the MEK inhibitor compared with conventional chemotherapy. So here we see these differences. You can see basically the separation in outcomes. This group of patients treated with trametinib did significantly better than patients who had standard of care chemotherapy. And that's true whether we compare it to letrozole or whether we compare it to standard of care chemotherapy. So in summary, Dr. Gershenson summarized that trametinib should be considered a new standard of care option for progressive or relapsed low-grade serous carcinoma. And I guess, you know, that's the summary here. Lots of information that I just threw at you, but super important. MEK inhibitors now have lots of data behind them. These should be considered a new standard of care for patients with low-grade serous carcinoma in the progressive or relapsed arena. We also looked at enzalutamide. Interesting, maybe some activity. So this is an androgen receptor blocker. What's on the table right now for low-grade serous? Now we're looking at this trial, GY019. My friend, Dr. Amanda Nichols-Fader, has this open through the NRGR cooperative group. In this protocol, we're randomizing patients to paclitaxel, carboplatin, and maintenance letrozole versus letrozole monotherapy. That tends to be very well tolerated, versus just letrozole alone. So that's a huge change. So here we're looking at the primary endpoint of progression-free survival, and this trial is accruing well. So basically, this trial is going to tell us, are we going to totally go away from chemotherapy and instead maybe just use letrozole alone for our patients with low-grade serous carcinomas? Wouldn't that be amazing? We don't know that yet, but this trial should answer that question. So our take-home points for low-grade serous carcinoma, big time changes include consideration of MEK inhibitors, and the one that we tend to think about in terms of potential approval is trametinib, and the protocol that's open for that is GY019. Okay, take a breath. Now we're going to switch to mucinous carcinomas. Not as much information here. You know, these patients with primary mucinous ovarian carcinoma, they're rare, but these patients often present with huge tumors, big masses with a lot of this mucinous ascites that you can see here. These patients, it's hard to diagnose sometimes, even for our pathologists, whether these are benign or borderline LMP or invasive cancers, because a lot of times they can all coexist within one tumor. So determining that is a little bit problematic sometimes, and hard to determine at the time of surgery. So the keys are that we want to remove these without rupture in the operating room, and we do not incorporate nodal evaluation. We don't do nodes in the staging with these because they just don't go there. A lot of these actually come from GI primaries, so they're appendiceal primaries that then spread to the ovary secondarily. In fact, I just had one the other day. A lady literally just like this, who came in with massive abdominal increase in her abdominal girth. And it was an appendiceal primary that had spread to the ovary. So do we do nodes? The bottom line is no, we do not. We showed this at MD Anderson back some years ago that no lymph node metastases are identified, and it didn't change outcome whether lymphadenectomy was performed or not. These patients also actually overexpress KRAS, and sort of similar to the low-grade situation, they just don't respond very well to the conventional taxane and platinum therapy. And so we see this red line, lower is worse. The red line is the mucinous tumors, and they just don't do as well as other types of ovarian cancer, either for progression-free or for overall survival. So we looked a few years ago here, GOG 281, to see if using a GI regimen, oxaliplatin and capecitabine with or without bevacizumab, would that be a better approach? Unfortunately, trial closed early. These are tough tumors to study because a lot of times they're identified incorrectly, either from where they started, the stage, the cell type, whether they're invasive or not. And in fact, only 5 of the original tumors were actually correctly identified as true primary mucinous ovarian cancers. So we really don't have any more information on this because GOG 241 was closed. So our take-home points for mucinous tumors, carcinomas, accurate diagnosis is really tough. We don't do lymphadenectomy here. We do consider capecitabine and oxaliplatin like a GI regimen plus or minus bevacizumab instead of paclitaxel carboplatin, but we just don't have great evidence for that. And if we do clinical trials in the future, central pathology review absolutely needed. So here we are, our last epithelial tumor we're going to talk about is clear cell carcinomas. And these are really very different. They tend to be seen more commonly in Asia, specifically in Japan, and they're associated with thrombosis, so DVT, PE, and hypercalcemia. So very different tumor type. They even look differently under the microscope. These tumors tend to occur in patients in their late 40s and 50s, so a little bit earlier than high-grade serous carcinomas. Early stage patients have a good prognosis. Late stage patients have a worse prognosis and tend to be very platinum resistant. In these tumors, we've really looked at sort of this different arm of targeted therapy. So do PI3K and AKT inhibitors or mTOR inhibitors work in these patients? And so we've looked at this in a number of different ways, looked at sunitinib, looked at nintedanib. Sunitinib, a remarkable failure. Unfortunately, it just didn't help PFS, progression-free survival of only 2.7 months. We looked at temsirolimus with paclitaxel and carboplatin, followed by temsirolimus. Lots of therapy there with this mTOR inhibitor, and basically no difference than compared with historical controls in any patient population we've studied. Dasatinib, we saw no responses in this group, and pembrolizumab and epacadostat, the patients accrued. The initial evaluation showed that we needed to increase the dose, but industry decided not to further develop the drug, so the study was closed. Cabozantinib is currently ongoing, looking at this drug in clear cell carcinomas. And there's several other drugs nationally and internationally that are being studied in patients with clear cell carcinoma of the ovary. So the bottom line for clear cell is keep working on it. Hopefully we can accrue to GY014, which is tazemetostat, and Bouquet, GOG 3051. This is super exciting. So I was fortunate enough to have helped design this trial and be involved in this on the steering committee. This is a really cool trial. So this is the Bouquet trial. You know how we send off our specimens to for molecular profiling in ovarian cancer. So in other words, when your patients come in, we not only send them for genetic testing, but we send them for genomic testing to tell us, what pathways are overexpressed, what mutations do we see that are targetable in the actual tumor itself. Well, now we have a trial to actually look and say, can we find active drugs for you? This is incredible, actually, because these arms, the actual arms aren't actually important. What is important is that these arms can get switched in and out as they fill, so that we'll be able to study a whole bunch of different options for patients and hopefully come up with really good options for our patients with these targets. So for example, like ipatasertib and paclitaxel, we think will have activity for patients who have PTEN, PIK3CA, or AKT mutations, right? So we can use that molecular profiling information that we get. And then for these patients with rare epithelial tumors who previously have had, no good response, no good options when they recur, now we have targeted therapy. So this is really cool. Even patients with like malignant Brenner tumors that clearly wouldn't, so rare, you'd never have a way to put them on a trial and find something that might be useful. Now we have that. So really interesting. So keep your eyes open for this, and please do consider referring your patients to centers in your area for this trial if you have rare tumor types in your patients. Okay, we're going to switch to totally the next bucket. So this is germ cell tumors. Germ cell tumors include dysgerminoma, yolk sac tumor, also called endodermal sinus tumor, immature teratoma, mixed primitive germ cell tumor, and choriocarcinoma. These tend to happen in younger girls and women, so in teens and very young adults. They're 10% of all ovarian cancers, and fertility becomes really important in these patients. Usually in these patients, we can spare one ovarian tube and the uterus, and so we can almost always conserve the uterus. In addition, something that we've been able to see very recently is that we can use assisted reproductive technology to preserve eggs beforehand, so that we can effectively treat these patients and still maintain their fertility. When we do that limited surgery, it doesn't refer to just taking out the ovarian cyst. It really does refer to taking out the involved entire tube and ovary on that side for germ cell tumors. Also important, we do perform lymphadenectomy in these patients currently in adults. So when we talk about dysgerminomas, they're about 50% of germ cell tumor patients. The other majority of them are split between yolk sac tumors and immature teratomas. This is what they look like. This is what a dysgerminoma looks like. And a yolk sac tumor, an endodermal sinus tumor under the microscope, looks a little different than any other tumor. An immature teratoma has a large amount of neural tissue, but has all three germ layers represented. So like endoderm, mesoderm, ectoderm. In general, we've treated everybody with bleomycin, etoposide, and cisplatin BEP chemotherapy, except for patients who have stage 1A, grade 1, pure immature teratomas or dysgerminomas. Everybody else got BEP, 3 cycles if totally resected, 4 cycles if not, or if they had stage 4 disease. Important not to omit bleomycin in this. So again, this is historical. And so remember, today we're talking about progress in rare tumors. So interestingly, the gist of all the progress made in germ cell tumors is by limiting who has to be subjected to chemotherapy. So what we're looking at here is saying, okay, we can actually not treat a number of patients who historically would have been treated and treat them if they recur with really great outcomes. So in other words, in general, about 15% of patients with early dysgerminomas recur and are cured with BEP. And so if we do not treat some of these patients, it looks like we can actually cure them. There have been 6 reports of this actually over the last 20 years. And what we see is that about 16% of patients relapse, and all but 4 patients, so 85%, were salvaged after relapse with surgery and chemotherapy. So basically that's a 98% survival if we sort of exclude the worst tumors. The bottom line is, it looks like we can probably safely sort of skip BEP chemotherapy in patients with very early stage germ cell tumors, as long as they don't have yolk sac mixture embryonal carcinomas, because yolk sac, they tend to do much more poorly than all other histologies. They're different. They're just more aggressive. So the idea behind limiting therapy is that it may be acceptable to watch and wait for any patient with stage 1 dysgerminoma or stage 1 grade 1 immature teratoma. There are studies that are looking at this, both in the pediatric and the adult populations. And specifically, there's this AGCT 1531 clinical trial that's looking to define that low risk germ cell tumor observational cohort, so that hopefully we can omit toxic chemotherapy in about 85% of patients and who wouldn't otherwise need it, catch the 15% when they recur, and successfully treat them only if they recur. Again, leading to a cure. These patients are incredibly susceptible to chemotherapy. Their tumors shrink away. We also are looking at neoadjuvant chemotherapy in germ cell tumors in the yolk sac advanced component. We'll switch to sex cord stromal tumors. So these represent about 7% of tumors, and these are largely granulosa cell and Sertoli Latic cell tumors. There are a couple of really important details here. We'll start with adult granulosa cell tumors. They're not that rare. Like, you will see them in your practice. We've identified the C to G point mutation in the FOXL2 gene that leads to these adult granulosa cell tumors. You know, unfortunately, a lot of times we'll see folks who've been overlooked. They've been told at their diagnosis that this was a benign condition, and it's not. It may act benign in a proportion of patients, but another proportion of patients, it does have malignant potential. And so we absolutely need to make sure we follow these patients. They can recur many years after they're initially diagnosed. Juvenile granulosa cell tumors, most of them, of course, are in adolescents and teenagers. They are more aggressive than the adult type, and so we treat with chemotherapy for anybody over stage 1A disease. Because again, they're not benign. 5 of 9 patients in this small report who recurred did die of their disease. They tend to be very vascular. This is a CD31 stain, and you can see all these blood vessels that are outlined in brown. They're very vascular. Sertoli Latic cell tumors are a little bit different. You can see they look different, and they're mostly unilateral. This is something where Sertoli Latic cell tumors, they're described differently and they act differently. It's a lot of how we treat these patients is based on the details in the pathology report, because you can see well intermediate and poorly differentiated tumors. And so with these patients, we treat any patient with stage 1C or greater, poorly differentiated tumors of any stage, including 1A, and patients who have heterologous elements. So anything that is not native to the ovary, including stage 1A. So I actually keep this information. Nobody remembers all of this. It's so rare, but I keep this information so I can, when I have a patient with Sertoli Latic cell tumor, I bring their pathology report in, I look at this information, and I decide if they need to be treated or not. What's so cool about the Sertoli Latic cell tumor is that Chris-Ann Schultz at Minnesota and her team actually identified that Dicer1 mutations occur in Sertoli Latic cell tumors. And what's so interesting about this, so this gene basically has been seen in families with PPB, pleuropulmonary blastoma family tumor and dysplasia syndrome. I like to call it PPB because I can't say that very often, the long descriptor. But the bottom line is that these kids, these little babies, if they're identified with PPB early on, they have a 90% survival. But if there's a late diagnosis, 60% of them die. And so when patients with Sertoli Latic cell tumors are identified, they need to be screened for Dicer1. If they're positive for Dicer1, which is present in about 70% of them, their entire families need to be screened for Dicer1, because if somebody knows they have that gene and they have a baby, they can be tested to see if their baby has that. The baby can be surveilled for pleuropulmonary blastoma, PPB, and then they can be effectively treated. So yes, it's rare, but wow, what an incredible thing that we can identify this issue. And, the ripple effect extends so far beyond just, identifying a really rare tumor in a patient. So pretty cool story. There have been a lot of surgical advances. Again, we think about fertility, fertility preservation, and historically, minimally invasive surgery was not an option, but really now it is. A lot of times we can spare one ovarian tube and the uterus, and again, use ART, assisted reproductive technology. We know that this is safe. Again, it doesn't refer to a cystectomy, really referring to removing the entire tube and ovary. In this, however, we don't routinely do lymphadenectomy unless the nodes are enlarged, because we looked back at this and found no patients had positive nodes with granulosa cell tumors. So the good news is we can omit routine lymphadenectomy. That's a major surgical advance. We also use secondary cytoreductive surgery in these patients. Here you can see this patient has a very large tumor in the upper abdomen where her granulosa cell tumor has recurred. Systemic therapy has changed tremendously. We based our treatment so many years ago just on, as you can see, a handful of patients, 11 patients in this study, 9 patients in this study, even GOG 115, 57 patients who were treated with BEP. Yet that became our standard for a really long time. When I was in fellowship eons ago, we started looking at taxanes and platinum, and what we found was there was a lot of activity. And so we actually moved forward. This is breaking information. So GOG 264, we looked to say, can we skip BEP? Can we instead look at paclitaxel and carboplatin instead, because we think it's less toxic? And in fact, what we found was that there was no difference that we could discern between BEP and paclitaxel carboplatin, and paclitaxel carboplatin, as you might expect, was a whole lot better tolerated. So I think it's safe to say, this paper should be coming out shortly, that paclitaxel carboplatin is acceptable to be the new standard of care for patients with upfront, advanced stage, or recurrent chemo-naive granulosa cell tumor and sex cord stromal tumors. So that's pretty cool. We've looked at paclitaxel in this setting, and as a single agent, it's not really very useful, but looking at weekly paclitaxel plus or minus bevacizumab, that does appear useful. In addition, Avastin alone in the recurrent setting, we found in GOG 251 to result in either a partial response or stable disease in the vast majority of patients. So just to summarize, I know it's a ton of information about rare tumors, but a couple key points for each one. So when we think about epithelial for low-grade serous, let's think trametinib and MEK inhibitors in the recurrent setting, and possibly letrozole in the upfront setting, and that'll be informed by GY019. For mucinous tumors, it's hard to diagnose, it's hard to study. There may be a role for a GI primary regimen in this type of tumor. Clear cell, we're working on it. Think about enrolling these patients to studies, and specifically for all your rare epithelial cancers, please consider the Bouquet trial. Germ cell tumors, really the take-home point is all about reducing the amount of BEP treatment for patients who have early stage disease. And for stromal granulosa cell sertoli lytic cell tumors, got to know our rare tumor buckets so that we do the right thing. Fertility sparing surgery is essential in these patients. And for sex cord stromal tumors, now we know that paclitaxel carboplatin are going to be first line. Other active agents include BEP, bevacizumab, weekly paclitaxel, and hormonal therapy. And we don't need to do nodes for staging in mucinous and stromal tumors. Lots of trials out there. Please think about them. And I think that's all I have to share right now. So I want to thank each of you for really taking such an active role in caring so hard for our patients. It's a tough thing to do sometimes, and it takes a whole team. So thank you very much for partnering in the incredible care of the amazing patients we serve. I'll just end with a statement. I don't care what you do in life, just leave a positive footprint in the world. And I think that everybody here clearly does that. My cell, my email are listed below. If ever you have a question about a rare tumor, please feel free to reach out. Thanks so much.